going to get started. Thanks for everybody for coming today. There's plenty of food in the back. Thanks everybody to join us online. This is again for our monthly MCHRI seminar series. Today we're very fortunate to have a wonderful lineup with Dr. Igbinosa and Lyell talking about iron deficiency anemia in pregnancy, a very important topic. But first, just wanted to then thank again the MCHRI Education Committee, shown here on the slides. They're a diverse set of amazing individuals from all around the campus who are providing input on the different types of seminars as well as the symposium and emerging issues. If you'd love to join us, please send out a note to the committee or myself. We'd love to have you as part of this education committee. Also wanted to point out, upcoming seminar for in a couple weeks is another fetal maternal medicine seminar, which is from Yair Blumenfeld and Kunchet, talking about challenges and opportunities for fetal and pediatric device development. This will be a very interesting seminar. Please make sure you join us. That's on May 22nd, again in 3 weeks. And that will also be both hybrid as well as in person over in the Red Oak Room with lunch provided. So that's a winning combination, so please join us. Also just wanted to point out, again, for you to save the date for our 6th annual Maternal and Child Health Research Institute Symposium on Thursday, October 19th. We use this symposium for MCHRI to highlight emerging issues in maternal and child health. And this, as outlined by our education committee, this is going to be an amazing symposium where we have a focus on climate-induced change in maternal and child health with representatives from different climate institutes around the country, including the Sustainability Institute here at Stanford and the Environmental Protection Agency. Session 2 will be the PedsNet, in terms of pediatric networking across the 11 major pediatric hospitals, and then an omics and maternal and child health session at the last part. And finally, again, groundbreaking research from Rising Star. So start to plan to submit your abstracts starting about late summer. You'll get the announcement. It's going to be a really amazing time, Thursday, October 19th.
MBA in November of 2021 presented.
So today I want to basically just highlight, oh, and also just wanted to ask if you're online, thank you for joining us, but if you just can mute yourself, please. Great, thank you so much. So today we have Dr. Deirdre Lyell, who's the Dunlevie and Endowed Professor of Maternal and Fetal Medicine, directs the Maternal and Child Health Fellowship as well, with Dr. Igbinosa, who's instructor in OB, talking about iron deficiency anemia in pregnancy. I'm going to let them start. First, Dr. Lyell, and then Dr. Igbinosa will follow. So, Dr. Lyell.
Great. Thank you, Tony, for that introduction and also for the opportunity to speak about this today. Iron deficiency anemia is the most common hematologic disorder of pregnancy. I don't know if you have our slides up. Terrific. It's the most common hematologic disorder of pregnancy, and it's a major driver of severe maternal morbidity, or SMM. We also know that SMM is something that disproportionately impacts historically disadvantaged communities. We know that too many pregnant people arrive at their birth admissions as well with untreated or undertreated iron deficiency anemia, and we are trying to change that. So we're going to talk today about just iron deficiency anemia in general. What is it? What is the state of anemia in pregnancy? We'll talk about anemia and maternal morbidity and mortality in the US in particular. Fetal and childhood consequences of anemia. I think that might be more relevant to those of you who practice pediatrics. Also just managing anemia in pregnancy, including opportunities like nutrition, oral and IV iron, and finally, research gaps in our ongoing work. So anemia is not just a problem in the United States, it's actually a problem throughout the world. And on this heat map, you can see that the areas that are the darkest have the most anemia. And in the very dark areas, a lot of this is due to like malaria. In the United States, 70% of anemia in pregnancy is due to iron deficiency. And it's important to remember that iron deficiency is really just the end product of a condition or state of iron depletion. And iron deficiency anemia is an end product of iron depletion during pregnancy and an iron deficient state. And unfortunately, at the very beginning of pregnancy, about half of women who are considered healthy are actually iron deficient in the first trimester. And about 25% actually have severe iron deficiency, where they have really minimal to no iron. We know that screening for this is suboptimal in pregnancy, and yet about 5 to 20% will go on to have deficiency anemia during pregnancy. This is for first-time moms, and we know that pregnancy doesn't help somebody who's iron deficient. They're going to become further iron depleted. So if that's not corrected, when they go on to have another baby in the future, it worsens with each pregnancy. Let's talk a little bit about iron requirements during pregnancy. So how much iron we have in the body is really determined by intake, loss, and storage. Menses or someone's period really can lead to chronic iron deficiency. Some people have very heavy periods and they are chronically iron deficient. It can be hard to overcome. But during pregnancy in particular, the second trimester is the time of the greatest iron requirements. And this is due to maternal blood expansion or blood volume expansion. In the third trimester, if you follow the purple line around, the fetus and the placenta really take up and utilize most of the iron. This is a graphic that just shows the same thing of what I just showed, but if we look at how much is required by each area, expansion of the maternal blood cell mass or maternal blood volume expansion really requires the most iron, followed by fetal and placenta, and then baseline maternal just blood loss or baseline turnover of iron. So that the total iron needs in pregnancy are about 1 gram per pregnancy. A lot of this comes from iron stores, maternal iron stores, and the rest comes from intestinal absorption that actually increases a bit during pregnancy. And you can imagine why this matters at delivery. So when we compare somebody who's not pregnant to pregnant, non-pregnant, about 4% of the blood supply goes to the uterus versus during pregnancy, it's about 20%. So blood volume to the uterus increases about 5-fold. And that's really because it takes a lot of blood to grow a baby. You're growing a baby, you're growing a placenta, you're growing the whole thing in a healthy state. And you can imagine at delivery when something goes wrong. So somebody delivers and the uterus doesn't contract down properly. Mom has a severe what's called uterinatony. Someone can bleed to death actually within 5 minutes. It can be rapid. So that begs the question then, why would you go into that state without a full tank, without kind of being fully optimized? And there's definitely opportunity to do better here. We know that anemia at delivery not only leaves that person with less buffer if something happens, like a pretty significant bleed, but anemia itself is a contributor to some major maternal morbidity. So placental abruption that affects the fetus, newborn too. But anemia also causes more hemorrhage, infectious morbidity, preeclampsia, as well as prematurity. We know that this is more common for the more severe forms of anemia with a hemoglobin of between 7 and 9, particularly if we look at outcomes of blood transfusion and infectious morbidity. What's concerning is that the much more common state of mild anemia also has these associations. We know that in addition to blood transfusions, in addition to infectious morbidity, we often or also see more conditions like preeclampsia and hemorrhage. There's an important racial and ethnic disparity here. We know that in general, so when Black versus white women have been compared, the rates of iron deficiency anemia are about 2 to 4 times increased among Black women. Among Hispanic women versus white women, there's about a 1.5 to 2-fold increase. And anemia itself, therefore, may exacerbate other disparities. We know that compared to white women, Black women face about 2-fold increased rates of the severe maternal morbidities that I mentioned, and this can be regardless of sociodemographic factors, things like education and income and other comorbidities. Anemia, as I've mentioned, increases the number of other SMM events, and we know that SMM it puts somebody at risk for death. And Black women, we know, are about 3 to 4 times more likely to die in childbirth than white women. And no one has kind of linked all the the dots here connected all the lines. I think that these are studies that are hard to do. You know, death luckily is a less common outcome, but it's not a stretch to imagine that these things are all related. Dr. Igbinosa led a project here where we looked at trends in antepartum anemia in California among pregnant patients, and the numbers aren't great. The upper line is among Black women, the lower line shows it among white women. It's increasing actually for all racial and ethnic groups. You'll see a more full slide later. But it's increasing among all groups, and the disparity, though, is getting worse. And we would ideally like to see that disparity between Black and white, those lines converge. We're headed in the wrong direction. So why is that? There are a lot of drivers of antepartum anemia. This includes obstetric comorbidities. So if somebody in pregnancy is having a lot of bleeding ongoing, then that's certainly going to contribute to anemia. Diet, inadequate screening in pregnancy, though, we're drivers too. How we're treating people in pregnancy, screening for anemia, following it up in medicine there's room for opportunity here. Social determinants of health have all been associated as well. We know that education, insurance, country of birth, prenatal care are all associated. And in fact, more than 10% of those who are getting WIC have anemia. There's a lot of nutritional insecurity in the United States, and this is a contributor. And it's important to note that racial and ethnic disparities are very real here. And some of this is due to structural inequalities that put such high numbers of our Black population in particular in these categories of social determinants of health that may independently be drivers too, and then also structural racism. So a thing that surprised me as an obstetrician is that I was never aware that there is an impact of maternal anemia on the newborn or the child. And this is really, you know, the data they're out there, they're fairly consistent. There's not a ton of data, but what's out there is quite consistent that there's a generational impact here. That iron deficiency anemia during pregnancy impacts the fetus, the newborn, and the child. What's been shown fairly consistently are impacts to preterm labor and low birth weight. This is a systematic review. It looked at across trimesters, it looked at low, middle income, and high income countries, different continents. And the associations are pretty consistent. And what has been shown is also a real dose response curve, that the more anemic you are, the stronger the associations, particularly perinatal mortality, which is mainly made up of low birth weight and preterm birth in these studies. Anemia has also been associated consistently with neurodevelopmental negative outcomes. Maternal anemia diagnosis before 30 weeks has been shown. There have been studies done at birth to 2 months, 9 months, 3.5 to 4 years, and 10 years. And they variably but consistently demonstrate impairments in either recognition and memory, motor function, depression and anxiety, autism spectrum disorders, also ADHD. One theory is that the hippocampus needs critical substrates for development, particularly iron, and that if you are iron deficient at a time critical for a hippocampal development, that may be the mechanism. And that might explain why some of these findings are independent of anemia correction. So if you're very iron deficient, I don't think anyone's fully linked all the dots, like at what point in pregnancy, you know, is it going to have the biggest impact? I don't think we know that. Finally, anemia severity has been linked to postpartum depression. Now, as people who take care of moms, this is very important to us, but we also know that depressed mom has an impact on the child, the infant, the newborn. That there's a there's a family effect here that's really quite important. So we're going to talk a little bit about how do we define anemia in pregnancy. World Health Organization defines it very slightly different than ACOG and CDC, but essentially they look at it's hemoglobin less than 11 or 33% hematocrit at any time during pregnancy per World Health. These are lower numbers than what non-pregnant populations have, simply because there's a dilutional effect during pregnancy. There's a lot more extra fluid, basically, and these things get diluted, hematocrit in particular. ACOG and CDC defines it as hemoglobin less than 11 or hematocrit less than 33 in the first and third trimester. And then in the second trimester, when there's a greater dilutional effect, it's less than 10.5 and less than 32%. So who should be screened? Everybody. I mean, it's a recommended, it's recommended as just part of basic prenatal care that people be screened when they come into pregnancy and between 24 and 28 weeks. How we screen is less prescribed and less recommended, and we think that that's a bit of a problem as well. The approach is most typically done by just a CBC or a complete blood count, but um, serum iron and ferritin levels will do a better job of identifying who's actually iron deficient. So what we are taught, what we do is we screen for anemia. First visit, you're not anemic. But people often don't look for at the ferritin or serum iron. So we don't really know. We're not really looking for iron deficient states. Transparent saturation, peripheral smear, and hemoglobin electrophoresis are also other ways that can be other things that can be helpful. To evaluate for iron deficiency and anemia, the serum ferritin I mentioned, that's actually probably the most efficient lab test that we can order to diagnose iron deficiency. When it's less than 30, then that's more than 92% sensitive and 98% specific for iron deficiency. The problem is that a lot of labs, including our own, use a much lower cutoff. So, I've talked to providers here where somebody's level comes back at 20, 22, 24, and they're saying, well, she's not iron deficient. But actually, because our lab says, it's either less than 12 or 15, that's fine, and people just leave it there. Yet we know that less than 30 has been shown to diagnose iron deficiency. We know that ferritin is also an acute phase reactant. That means that it can be falsely elevated. So if somebody has had a cold or they have some type of inflammatory state, perhaps a rheumatologic disease, it can be falsely elevated, but if it's low, that's a true low. And it's important that we act on it. Transferrin saturation is another good tool, particularly in those states where the ferritin may be high, that if it's low, then it should really be diagnostic, less than 20% of iron deficiency itself. When we treat patients, we should see a response in 3 weeks. So during prenatal care, people should be screened, treated, and followed up on the treatment. And we know just from a lot of data that doesn't necessarily happen as frequently as we'd like. And that's why so many people, again, are coming to their birth admission iron deficient. I think it's important to look at, until recently, there has been a race-based cutoff in terms of who we consider anemic in pregnancy. This came from a 1993 NHANES 2 study where hemoglobin 0.8 grams per deciliter lower was typically more common as the average in healthy Black women who didn't have signs of iron deficiency. So they created a recommendation adopted by ACOG that we use a lower cutoff in a Black population of 10.2 to define anemia. And the problem here is that we are already undertreating, and in particular, this is a population where there's a disparity, and there's a lot more of the poor outcomes that we're concerned about, and we may be actually contributing to those. Ham et al., a group out of, I believe, Columbia, Penn, actually did a very nice study in 2021 where they identified in their own population Black pregnant patients who had antepartum and hemoglobins between 10.2 and 11, who would have otherwise been treated if they weren't Black, were more likely to come in at their birth admission with hemoglobins less than 11. That's not a total surprise, but it's a good reminder that often hemoglobins don't build up on their own during pregnancies. But among the entire cohort, those with hemoglobins under 11 were threefold more likely to require blood transfusion. And the question we all have is, well, what about the Black population? And they weren't powered to really show a difference. There were trends, and I think that we all assume that this is something that matters. And ACOG has since removed this difference, and so we treat everybody the same. We no longer have these cutoffs. I'm going to turn it over to Dr. Igbinosa now, who is going to take us through the remainder of the talk.
Thank you. Thank you, Dr. Lyell. Can you hear me okay? Yeah, okay. All right, so I'm gonna talk about management options. First, I'm gonna talk about nutrition as an intervention. So the Institute of Medicine recommends 27 milligrams of iron a day during pregnancy, and that's most commonly seen in prenatal supplements. But often you should think about, like, what is nutrition? Is it fortification of food? Is it actual food? And so looking at the trials, there's a 2021 Cochrane review, and out of 75 dietary intervention trials, only 3 of them were actually food-based. And so the rest of the trials were actually about iron supplementation or micronutrients with vitamin D or vitamin C during pregnancy. And then there's a 2022 systematic review on nutrition RCTs, mainly, again, just looking at dietary interventions. And this was a little bit more specific. It was iron fortification with maybe a nutrition counseling. Only one of those studies looked specifically at nutrition counseling. And the conclusion was that generally nutrition counseling made sense, but there was overall high bias in these tools. So I say that to say that there is not a standard approach to how we give nutrition counseling in pregnancy. And so that's a gap in the research. So what is the standard of care? The standard of care is oral iron. And oral iron can be given from 40 to 200 milligrams of elemental iron. There's a lot of different formulations out there. It can be, there's a long list, but overall, the goal is that they should at least get that amount. A common issue, though, is the side effects. And in some studies, side effects of oral iron is as high as 70%. And so if you can imagine, if our standard of care is oral iron and you're anemic, and then you're given a treatment option where you have a 70% risk of having a side effect. So continuation with that treatment is not frequent. And so there's more recent literature showing that how can we maybe improve that absorption, and giving it every other day versus giving it daily decrease that risk of side effects. And so this is out of a Cochrane review where basically, I will say for the intermittent on this Cochrane review, they included studies who did as far as like just twice a week versus every other day. So the intermittent category was pretty wide, whereas the favors daily was pretty stringent. And so in the non-obstetric population, there's good evidence to show that giving iron every other day is effective. You have more absorption, and a lower dose is actually more effective than a high dose given every other day. So basically, if someone was anemic in obstetric practice, they might, prior 10 years ago, they might get 2 to 3 tablets of iron a day, every day. And that has actually been shown not to be effective. And so it's actually better to give them 1 tablet every other day as opposed to even 2 tablets at once every other day. So that's another way to kind of think about that study. And so, okay, oral iron, you have some okay evidence, it might work. And then what is our other option? Is intravenous iron. And what are our recommendations for that? And so it's recommended for people who cannot tolerate oral iron, or they have a malabsorption syndrome, often patients who have bariatric surgery, or they have severe iron deficiency anemia. This is generally not well defined in the literature at what is that specific cutoff that you should give IV iron. IV preparations, I should say new IV iron preparations, are generally safe. The first generation preparations had a higher risk of anaphylaxis. And so it wasn't a commonly used modality, but newer generations have a less anaphylaxis, less than about 1%, better safety profile. And so a lot of the RCTs on IV iron are actually not based in the US. And there's currently about 3 trials. We're doing one of them, different formulations of iron about that use in pregnancy. So exciting things to come. So what are the guidelines say about IV iron? So the United States Preventive Task Force says data is insufficient. Basically that the data from outside countries cannot be extrapolated to the United States. ACOG says IV iron could be used if the patient has intolerance. The Royal College of Obstetrics and Gynecology, they actually take a very different approach for all patients with a hemoglobin less than 10 at greater than 34 weeks, they recommend IV iron. So again, and that's based off of expert opinion. And then the Network for Advancement of Patient Blood Management actually recommends it earlier, 28 weeks. So you can just see from just here a sampling of 4 society guidelines, very different opinions on how to incorporate IV iron. And then just an additional consideration, is there a thing as overcorrecting? Yes. And so we do want to kind of stay within a ideal window. And it ideally less than 13. Hemoglobins corrected to above 13 have been associated with increased risk of small for gestational age infants, stillbirth, preeclampsia, and gestational diabetes. And Dr. Lyell went over a lot of the risks associated with, we're on the other end, on the lower end of that curve. And so here is one of our MCHRI funded trials, is a randomized controlled trial of oral iron to intravenous iron, 24 to 34 weeks in pregnancy. And our hypothesis is that if we supplement with IV iron, and our choice here is for moxetol, that we can actually improve hemoglobin indices better at the time of birth admission. And then we also, in terms of that last graph, wanting to avoid overcorrection, we based off a formula that has been used in other populations, kind of have a dose recommended how to treat the hemoglobin level. So for example, hemoglobin 9 to 11, they get 1 dose of pramoxetol, and then hemoglobin 7 to 9, they'll get 2 doses. And then comparatively, the standard of care would be the ferrous sulfate. We do it every other day, and then 2 tabs every other day. So where are we now? And I think the one thing that we really try to underscore when we talk about it is that iron deficiency anemia is preventable. We're not talking about hereditary anemias. We're talking about a nutritional anemia that we feel like has really been under-recognized. And iron therapy removes outcomes. So this study is out of Texas, about 7,500 patients with anemia, pregnant patients. And I'm going to talk about the 36% successfully treated, but I did want to call out that 46% of their population were untreated for their anemia in the study. And so that's just something that, again, that just really kind of underscores the gap in our care for patients and how we view anemia, is that why we're 46% untreated. Of the 36% treated, there was reduced odds of preterm birth and preeclampsia with iron. And in this study, they only treated with oral iron. So IV iron was not an option available for this in this study. So why is there still anemia after about 7+ months of prenatal care? It's under-recognized by healthcare professionals and patients. Screening practices are inconsistent. There are many different approaches to how you even evaluate and treat. Standard treatment has side effects, and there's absence of protocols to treat and monitor the response once you have decided to get someone on there. There's actually not really good plans on what do you do next. And so this editorial I'm sharing, iron deficiency in the United States, is from public health professionals really just trying to call out how this is not just an issue for pregnant women. This is iron. You saw the chart where anemia was going up the board, and when you look at other populations, they're seeing similar trends. And this critique is actually calling out our use of guidelines, and it says that we're basing a lot of our current evidence on old data. And so, when will we change and include that ferritin should be included, our transparent saturation? When will we acknowledge those things? So this is a very interesting critique. So our challenge is that our current approaches are not working. And we also know that iron deficiency anemia is also associated with disparities. And also in terms of all the literature that we shared, there were no studies that consider the perspectives of Black or Hispanic women on anemia in pregnancy. We also know that anemia is an important driver for transfusions and other maternal and neonatal complications. And so some of our solutions is partner with patients and communities to design better messaging and approaches to treatment, and work with providers, healthcare professionals to create and implement patient-centered solutions. So prior successes, we did want to call out that health equity and quality care initiatives can improve outcomes, and it can help narrow these gaps close gaps. And this is work done by Elliott Main and CMQCC with their maternal hemorrhage toolkit. And what you can see in the pre is the difference between Black pregnant patients versus this is grouped all other pregnant patients. And then you see the gap here in the first graph. And then after the intervention of the toolkit, you see how there is no longer a gap. But you could still argue that, hey, we still have an issue with hemorrhage and that we still can bring that down for everyone. And so one of our frameworks, I'll talk about a few of our approaches, is to how to use an anti-racist public health praxis. And this work by Dr. Chandra Ford is really talking about how do we use race in studies and how do we center voices. So we've talked a lot about patients and the disparities, but now how can we then pull in their voice? And so one of our funded projects was a qualitative research study with one of our community partners, Black Prosperity and Wellness, Black Wellness and Prosperity Center in Fresno. And 2020, we did a lot of this in 2021 via Zoom with our partners, was really popular with our pregnant patients. We're able to do it after hours. And these are some of the quotes that I wanted to share, is that a lot of common language in doctor world isn't common language to us. For a provider, listening is very important. And then we need to find a way to navigate conversations around the process of birth, bringing a child into this world, postpartum healing, depression, in a way that doesn't instill fear, but get it inside. And so we started this project just to really talk about experiences with anemia. And a lot of the patients did not even know they were anemic. They said that often it didn't come up until the time of the delivery, and the conversations around it were they didn't feel like they were equipped to actually do anything about it. And so this is a paper that is underway. And so the other framework we used was the conceptual model, pathways to decrease disparities in severe maternal morbidity by Dr. Elizabeth Howell. And this is essentially the crux of it is how do you combine community and clinical wisdom to address anemia and birth inequities? And so this is looking at, again, in the literature, how do we look at race? How do we look at the social determinants of health? Can we find evidence of structural racism? Can we address provider factors? Can we address systemic factors? And then what you've seen is that there's a lot of gaps that we can address at multiple levels. So some of our research questions were, what are the trends of antepartum anemia by race and ethnicity in California? What is the intersection of social determinants of health and anemia by race and ethnicity among pregnant people in California? And so in this cohort study, we looked at births greater than 20 weeks from 2011 to 2020, and we analyzed the trends and prevalence of antepartum anemia by ICD-9 and 10 codes. And so our final cohort was over 3 million births. I will say we did exclude hereditary anemias, which is, I think that is a topic worth its own discussion and research, but we did just want to call out how this is not due to a genetic reason. It's really due to something that we feel like we can better treat and implement. And so in this graph, you see we stratified by race and ethnicity. And what was surprising to us, we knew, as you saw in the earlier graph, the gaps between Black and white pregnant patients, but we were surprised about the increase in Pacific Islanders in terms of their deficiency anemia, in terms of that rise that had not been previously reported, as well as varying incidents in terms among the American Indian, Alaska Native populations. And so by stratifying by race, again, looking at our frameworks, we actually are able to see issues that may be unique to a population. And then looking at intersections between social determinants of health and anemia, we saw that private insurance was actually associated with a higher risk for anemia among Black pregnant patients. And Black pregnant patients had a 2 times elevated relative risk of antepartum anemia, regardless of age and education. And so again, going back to what are the factors that we can address? And so another part of our studies that we've been working on is, can we estimate the contributions of anemia to severe maternal morbidity by race and ethnicity? Another cohort study that we did using multivariable logistic regression modeling and also calculating population attributable risk percentages, which is another way to say is, can we estimate the association of anemia with severe maternal morbidity. And so for this first graph, you'll see is that essentially the crude risk is among American Indian, Alaskan Native, among Black, among Pacific Islanders, pregnant patients. They had the highest relative risk of severe maternal morbidity. And then when we adjust for risk factors, and so things that we adjusted for were social determinants of health, parity, anemia, and type of delivery, you can see that closes some of that gap for some populations, but not as much for others. So it goes down for everyone, but we still see that our risk of severe maternal morbidity remains elevated, especially among the three groups that I've mentioned. And then can we estimate about how much of the anemia contributes to severe maternal morbidity by race and ethnicity? And so some of our groups have kind of wide confidence intervals, but on average, you can see among Black patients is about 21% of severe maternal morbidity is due to anemia. Same around Hispanic, which was also surprising because they didn't have the highest rates from before. But we, again, looking at our data kind of tells you more information and ways to target and target to intervene in groups. And then multi-race also was really high. So what are we doing with this information? And so another funded study that is nearing completion is our community engagement to develop a patient-centered approach to anemia and pregnancy, again, with our community partner and Black Wellness and Prosperity Center. And then we also kind of formed, as we started to see that this was just a lot bigger than we recognized, was like, who else can we partner with in the community? And so in that anemia community leadership group, we have WIC, Women, Infant and Children's, Black Infant Health, and other community partners from different hospitals. And so with that has also been more interviews and focus groups, just kind of understand, are there geographical differences and other things that we can account for? And with that, we are creating, identifying patient valued outcomes, modifying current existing education materials, and kind of really building out our toolkit of patient-centered material. And then our future steps is that, as you may recall, is that we talked a lot about the gaps in the research and then just the gaps with our current evidence among screening with healthcare professionals. And so that we have a clinical collaborative leadership, also working with CMQCC and Stanford in terms of how can we better as a group inform and educate providers. And with that, we have about 18 hospitals and we have a kind of a larger side QI intervention planned. And I know I'm coming to time and there's many people to thank. And I hope I included everyone. I apologize if I forgot anyone. But I would like to thank our co-author teams, many of the projects, our community partners, our CRCs who help really with our trials, our data safety monitoring board who for our RCT, like we have our partnerships is not just OB-GYN, it's with hematology, with nephrology. So there's a lot of different expertise and we just like to say thank you. And then last but not least, we thank our sponsors in terms of our WARHER grant, the Spectrum grant, and then the MCHRI grant, which was the first of the projects that were funded as a fellow that I was started on. So I'd like to say thank you to them. And that I'll take questions. We will take questions.
Great. Thank you very much. Wonderful talk, not just on anemia, but on a whole community project. Let's take questions from those that are in person first. Tell them your name too.
Hi, I'm Molly. I just am wondering, you were mentioning just rates of anemia are going up kind of across the board. I'm wondering if you have any sort of guesses as to why that is, just with everybody going up. Is there some environmental factor or what do you think is happening?
Yeah, thank you for that question. I will say we've looked into that and there's different hypotheses. So for the US, a lot of it is, a lot of the hypotheses centers around the diet the change in the Western diet, less fortification of foods. For example, like cereal, like that was like a very common thing that was in. There's just a lot of different foods that we just don't consume as much anymore, and so that has been brought up. There's also been brought up in terms of agricultural practices, in terms of how for those who eat meat, or how different foods are affected by that, and so the processing may kind of take a little bit away from the iron content. And so there's a lot of different things US based on that. And then globally, the conversation has been about the presence of infection and how that may, if an iron deficient state may make you more prone for infection. And so there's some like competing thoughts on how much to correct in places that are malaria endemic, and so there's different thoughts there.
Thank you.
Other questions?
Was there sorry. Was there a difference in the statistics versus from changing diet versus the iron supplements?
Yes. So generally the studies. Oh, so the question was there a difference, I guess, in outcome with taking the diet versus dietary supplements, right? Okay. And so in those systematic reviews, there was that it felt like diet was beneficial. However, the big caution was the bias. And so, for example, one of them, it said it was blinding, but in terms of the risk assessment, it felt like blinding was inadequate. It felt it was randomization for one of them was inadequate. A lot of the trials, like when you just put into blood med nutrition and pregnancy, there would be a lot of trials that would come up. A lot of the critique of that was that it was not well defined what was the dietary counseling or intervention. And so I think that is what pulled out so many studies that I would have thought had been eligible. So in terms of the ones that felt they were rigor, it's like, yes, but they didn't feel like it was a good statistical design to base future recommendations. But I will say the WHO does recommend nutrition counseling still. It's, food is good.
So twofold, I guess. Why aren't, it sounds like that some sort of low dose or nutritional change in everybody's diet can't hurt them. So why aren't like materials being provided at clinics, et cetera, to help people self-educate if they choose to? And then I guess subsequently, why are institutes like, Stanford or whomever else not testing whenever, like, it's just a blood test. So like, why aren't they testing whenever it's more likely to be caught then and have an impact that you could change if needed?
Good questions. And so I will say the first question is that there is general nutrition information that's provided either via app, your prenatal packet. And I think that's not unique to here. That's just a lot of like even ACOG on their website. But the question is that sufficient? And in the one trial that they felt was good in the Cochrane review is they studied actual counseling on how to cook your food. And so they use, for example, cast iron skillets, which we talk about a lot in our just meetings about how that's helpful. And so I think there could be, but there's definitely room for improvement there. And then the second one about screening, do you want to?
Yeah, that's it. Well, I don't have a mic. I'll come over here. I hope Zoom line can hear me. It's a great question. I do think that a lot of iron deficiency anemia is under-recognized and under-treated. And so, where does that come from? I think it's a hard question to answer. Some of that may be that ACOG recommendations in this area are a little bit suboptimal. They don't really acknowledge iron deficiency, so this precursor state that's so relevant. They also don't talk about what to do in follow-up. So when somebody is diagnosed, it's, I think people do well with standardization of care in certain areas. And I think this is one that would lend itself very well to standardization. I think in medicine, often people don't think about, something that you can just buy over the counter as simply very preventative of a lot of medical disease. And I think that this is a very good example of that.
Thank you.
Thank you so much. First, I just want to commend you on being on the cutting edge of community engaged research. It's really impressive to see all the partnerships that you've pulled together and the qualitative work. That said, my question's back actually more to the data and health service research. So, I mean, again, this impressive increase and to the question of testing, is that based, or is all this data based on actual measurements, lab measurements, or is it on recorded diagnoses? With the question, I mean, either way, if the frequency of testing is going up and we're just, maybe this is, a bias of we're just testing more.
I think that's a great question. And so I will say this is based off of ICD-9, so electronic health record data. We have not done validation studies, but there is a group that has done validation studies and have shown that these codes are reliable. And so that's been helpful. But I think it is a valid point. And so I think as we kind of, scale up our operations, it's something that we're also looking at is like, how can we have laboratory confirmed iron deficiency, which is an issue that we have run into with our trial. And so one part of our trial has been like just kind of reinforcing that, confirming iron deficiency, it will actually help you further down the road, as opposed to treating empirically and then not knowing if like what you did worked or didn't.
And then can I add one other piece to that is that we are looking at in our large scale intervention that includes sites from California, Oregon, and hopefully soon Washington. We'll be looking at hemoglobin at birth admission. So we'll have the actual measure, and that's what's novel here because people haven't been able to do that at scale. But through utilizing the CMQCC Maternal Data Center, we'll be able to get those data. But I agree that it doesn't, I don't think that this is just measurement error. I mean, I think it's an important consideration, but others have shown these trends, and there's not anything other than the switch to ICD-9 from 9 to 10 that has really changed here in terms of practice, anything major that's come out in our field to really drive that.
Rebuttal?
No, I just had a tangential question. I was curious fundamentally because you made a comment about the processing, and I'm guessing we do more processing in more first world countries. And so like if some of these demographic populations that suffer, if they suffer worse in first world countries than they would have in their native country because of the lack of the processing, that might change the nutritional value. Does that make sense?
So if I understand the question, is you're saying that if someone was from a lower resource rich country, a low resource country, and they come here, how does that food impact?
Yeah, you'd mentioned that sometimes the processing of the food changes the nutritional value of the food.
Yeah.
And so if like, if my Mexican family were to move here, like does their non-processed where they probably came from previously would have helped them better actually versus being here? Or you guys, have you seen that yet?
Okay, thank you for clarifying. I think so it's twofold because you could argue based off of that world map that we're not as high as other countries. However, when we look at our data, I think in terms of, for example, Hispanic born in the U.S. versus not born in the U.S., we have seen that it's a little bit that it's higher for that born in the U.S. versus those who were born outside of the U.S. But it's smaller numbers, and I don't think we haven't. I think that's something that we can flesh out a bit more. But these are things that we've had kind of that question like, how much can we say is our diet here?
Question. I have a question from the pediatric side, which is there's a outcome association with autism and other neurodevelopmental issues with iron deficiency anemia. So two questions. Can you elaborate a little bit more about that? But also, neurodevelopment occurs before 24 weeks, yet you're testing at 24 weeks for anemia. So shouldn't we be testing earlier? And can you comment on that?
Yeah, so let me start. So we do test early. We're supposed to test once the patient shows up for prenatal care with a CBC, but not with the iron deficiency. And then again at 24, 8 weeks. But in terms of looking for iron deficiency specifically in the absence of anemia, that's not a standard yet. And then I know you really like neurodevelopmental outcomes. I can comment on it. I can say that in that study, they grouped less than 30 weeks. And I think that's why they called out that with pregnant patients with anemia less than 30 weeks were the ones at higher risk of having infants and children with those neurodevelopmental outcomes. And then they stratified it by intellectual disability, any intellectual disability, autism spectrum disorder, and then ADHD, and among others.
But I think your question highlights the importance of like partnerships with other fields, because I didn't know that neurodevelopmental issues happen before 24 weeks. And so that's a helpful question. We're just reading other people's data and literature here, but in our prospective protocol, we're pushing for adding serum ferritin in the first trimester to that CBC because we're missing iron deficiency. So we get people who come into pregnancy, they're not anemic, but they may have a very, very low ferritin, which suggests that they're iron deficient. They're on the path toward anemia. Whether that happens between, by 24 or 28 weeks, who knows? But when we, in prenatal care, these protocols weren't designed, with the knowledge that that iron deficiency earlier in a pregnancy would really matter to the newborn. And I think this is emerging and really important question. Thank you.
I don't think it's known if it matters or not. Just that there's a lot of the development of the entire body goes on before 24 weeks, and the rest is just kind of elaboration.
But I know there's a lot of brain development later, like the brain size at 35 weeks is 2 at 39 weeks. And so in terms of like when a hit happens, I don't know that we know that for sure with, with anemia, but does like neurodevelopmental harm, is that more common with earlier anemias? I don't know.
Yeah. That'd be interesting to understand.
Yeah.
Another question if time allows. Looking at to this question of causality, which I think is fascinating, and I think, there's a lot more research needed just in nutrition in general. We don't want this to be vitamin D. We're like just focused on iron, and really maybe these other outcomes are just, it's a proxy for nutrition, poor nutrition in general. But the clear link is to anemia. And then for the SMM work, did you look at how much of that was driven just by transfusion? My understanding it's common to just look at SMM without transfusion, and sort of that. I was looking for that third column of odds ratios. Did it disappear in significance, or is most of the SMM correlation driven by the need for transfusion, or does it also appear to have impact on the other maternal morbidity?
Great question. We have a paper coming out with that exact look, but to answer your question, so this SMM included blood transfusion only codes. So SMM, just for context for everyone, it can be like 21 codes, but for SMM it's largely driven by blood transfusion. And so then we looked at, what if we take away blood transfusion only codes and just look at non-transfusion SMM? And we did still see a correlation, not as strong, but we still saw the disparities. And so our conclusions is that non-transfusion SMM may be correlated to like higher morbidity among the pregnant patients. So often those other codes could be like end-stage renal disease, they needed dialysis, they had a pulmonary embolism or other things. And so, but to your point, yes, it is something that we were curious, how much of this is just blood transfusion related?
But I would also add, like, we don't want to write it off like blood transfusion because that's actually a morbid outcome as well. And, sometimes we see transfusion of multiple units and people ending up with transfusion associated lung injury or other complications like that as well. And so I think that in the study we showed, there was also association with conditions like preeclampsia and also just hemorrhage itself, that we know that anemia begets a higher risk of hemorrhage, probably through the path of uterine atony. So we can do a lot to even prevent any of this.
We didn't even ask our people online, but but thank you guys so much.
So,
I know we're
I know
probably
we have time for one or two more questions. Anybody online want to unmute and join the fray?
okay.
All right. Hearing none, I'll just join me in thanking Dr. Lyell and Dr. Igbinosa for a wonderful and stimulating conversation. And we'll see you in 3 weeks with Dr. Blumenfeld.